Okay, it's 11:04. We will start with the webinar. Good morning to all of you who have joined here on this Sunday morning. This is our 36th webinar, 36th CD program, and 34th webinar from the IDA Malabar 2020 side. Warm welcome to all of you. The faculty for today is an oral surgeon, Dr. Aswathi Vinod, currently working as the assistant professor of Department of OMFS, KMCT Dental College. She did her graduation in 2013 and post-graduation in 2018. She has already presented many papers and publications. The most recent one was in Malaysia, International Paper Presentation at World Dental Conference 2019. Dr. Aswathi, over to you, ma'am, for the webinar.
Thank you, Nikushan Doctor. I thank all the office bearers of IDA for giving me this platform. Thank you to all of you. A warm good morning to one and all. My topic is how to make Impaction effortless. Before that, let me wish everyone a very happy Kerala Piravi. Today is November 1st. Wishing you all a very happy Kerala Piravi. Moving to my topic, how to make Impaction effortless. Though this topic tells you that you can try making Impaction effortless, it is never. You cannot take out an impacted tooth with some effort. You need some effort to take out some tooth. Whichever tooth it is, you need to put some effort in that. So I'll be discussing how you can distinguish a tooth. How can you make out whether you can remove it normally or whether you need to go for a surgical removal. Do you need a specialist to remove this tooth? That is what will be discussed in my session. A good surgeon knows how to operate. A better surgeon knows when to operate, and the best surgeon knows when not to operate. Always keep in mind when you should not operate a case. This is the important thing to be kept in mind. Whichever procedure you are going to do, the point to be noted is when not to operate. How do you understand whether you should attempt this case or you should not proceed? Starting from the case history, starting from day one when the patient comes to you, from then you should see how the patient is, what is the attitude of the patient, what was their chief complaint, do they have any medical history, what is the status of their tooth, and is there a need to proceed with that patient or not. That is to be kept in mind. My chief complaint is that you are complaining. This becomes an issue to every one of us. That is, if the patient comes to you with a decayed tooth and the patient asks you to restore that tooth, you check the patient and you are understood that there is impacted tooth, there are multiple grossly decayed tooth, some tooth need to undergo RCT, etc. What you do is you explain all this to the patient and you try motivating this patient for extraction or surgical removal. That becomes an headache for the surgeon. If the patient is not willing for the procedure, then just leave the patient. If you motivate this patient and if you extract or you surgically remove a tooth, that becomes a headache later. There are some anticipated complications which are unavoidable, and if a particular tooth, an impacted tooth is symptomatic, and if you go for a prophylactic removal, this patient starts blaming you for that. It was you who told me to remove the tooth. That becomes the tone of the patient. So mainly focus on the chief complaint. If the tooth is asymptomatic, then please don't proceed with the surgical removal. Next one is medical history. Whichever case it is, let it be an extraction or a surgical removal, medical history has its importance. Always focus on the medical history. What are the drugs the patient is using, whether he has any systemic issue, whether there is whether the patient is immunocompromised, is there any liver dysfunction, renal dysfunction, any cardiac history, etc. Manage the patient accordingly. If there is any cardiac history, the patient will be telling just patient is having breathlessness on exertion. That will be the only complaint patient is telling. It is you who has to motivate the patient and send the patient for a medical consultation. If not, what will happen is once you give this adrenaline, LA with adrenaline, there are chances for the patient to develop some pain or some difficulty during the procedure. In order to avoid that, this is a rarer scenario, but still then please keep in mind, always rule out the medical history of the patient. If the patient has some liver issues or some liver cirrhosis or something like that, something related to the liver, if the patient doesn't inform you and you are not aware of this, what happens is once you start the procedure, you will be towards the end of the procedure. Once you are about to suture that, this bleeding doesn't stop. You will try to remove the granulation tissue, again the bleeding increases. Then only after so much of headaches, going through all these troubles, then only the patient will reveal that he had so and so issue. So always keep in mind to rule out the medical history. If that is a patient with some renal issue, then make sure that you are giving the drug which you are giving doesn't cause any issue to the kidneys. Okay, then there are chances of anaphylaxis. Recently we had a case which came to our clinic. What happened is patient has previous history. When we recorded the previous history, patient has a previous history of extraction which was uh, normal. Patient did not have any issues. That was very normal. Second time when we gave LA, we gave LA, we did the procedure, and we asked the patient to wait in the waiting area. The patient immediately developed itching. Okay, that is after single exposure, then only the body responded. So always keep in mind the risk of anaphylaxis. In a single episode there may not be any reaction, but there can be chance of anaphylaxis in the immediate next episode. This is what we experienced recently in our hospital. That is why this is more important. When since it was a hospital, we could manage it there. When it comes to a clinic, we get panic, we don't know what to do. So it is always better to keep emergency medicines in your clinic for situations like this. Then anaphylaxis is unpredictable, you cannot say, but if such a scenario happens, then manage accordingly. Then the patient can be anxious. For that, you can try for a pre-medication, etc. That is not usually practiced, but if required, then you can go for a pre-medication if needed. Then diabetes mellitus, hypertension, all that, maintain the scenarios, then only proceed with the procedure. Scaring that whether the patient, you might lose the patient. Never ever attempt a patient with a medical history without proper consent. That will become a headache for us. So always make sure that the medical history is ruled out. Then going into the oral cavity clinical evaluation. Uh, you can see this figure. You can see there is an impacted tooth. You can see there is a soft tissue coverage, and you can see 7 next to that. You can see what are the data you get, what inference do you come from this picture. You clinically evaluate the patient. The patient came to you telling that there's pain in the posterior region of your tooth. Okay, you examine the patient. What you see is, since there is a soft tissue coverage over this 8, you see only this 7. You see a completely erupted 7. You won't be able to see this 8. Clinically, when you see the patient, you will not be able to see this 8 since it is covered by soft tissue. There can be pericoronitis, some issue will be there, and you will not be able to see this 8. So same way, you will not be able to appreciate this caries which is developing between the distal aspect of 7 and the mesial aspect of this 8. This caries also will not be appreciated when you look at the patient clinically. You can see how the crown structure looks. What about the soft tissue, floor of the mouth, all that can be examined while you see the patient clinically. The opposing tooth, all that will be examined. And then if you patient complains of pain on 7, in this scenario mostly patient will complain of pain in 7. if you don't properly investigate. In such cases, if you don't properly investigate or evaluate this patient and take out this 7 or treat this 7, pain will not subside. The chief complaint, pain of the patient will not subside. So it is always advised, never hesitate to make a radiographic evaluation of the tooth before proceeding with the procedure. That is important for you to explain for the patient, for you to understand the patient, and you should understand what the case is, whether it is a mesioangular tooth, whether it is a distoangular tooth, or is the tooth missing, or is there any periapical pathology. For all that, you need a radiographic evaluation. You take an IOPA. So you ask the patient either to take an OPG, IOPA or CBCT. There are certain limitations for all this. So you have to correlate your radiographic findings with that your clinical findings to come at a, to derive at a proper diagnosis. You take an IOPA. Usually we advise the patient to take IOPA of say, for example, 7 and 8, lower 7 and 8. So ideally that IOPA will have a part of 6, 7, 8 with the roots of 8 should be included. Make sure that the roots of 8 are included in the X-ray with a part of the canal showing where the canal passes. That should be there in your IOPA. If that is missing due to some limitation, that is patient is having limited mouth opening or some other reason, if there is difficulty in taking an IOPA, don't hesitate to write for an OPG. Once you see an IOPA, please go forward, tell the patient and ask them to write and take an OPG. Never compromise on your evaluation part, because you don't know how the root is, or what is the situation of the 7, distal aspect of 7. You don't know that. You will find it difficult to convince the patient after treatment. So it is always better to take your evaluations properly before the procedure. So you take an OPG. Okay, what are the factors or what are the data you receive from this OPG? This OPG, you can see the condylar head there. You can see both the condylar heads. Okay, you can evaluate that. Then you can see your impacted tooth here. On both sides, you can see your impacted tooth. You can see the position of 7. Relationship of 8 with 7 can be evaluated from this. You can say that here you can have a tooth that is horizontally placed. There can be only 2 cusps that is visible here. Then you can have see the inferior alveolar canal going there. Okay, so these data, you can collect these data from this OPG. When you advise for an OPG for an anterior area, it is better not to advise OPG for the anterior tooth. Okay, for 8, it is fine. You can get, if there are multiple impacted tooth, it is always better to advise for an OPG than that of the IOPA. So these are the informations or inference you reach from an OPG. IOPA. The IOPA, what are the findings you get from this IOPA? You can see that the level of the tooth, that is the level of impacted 8, you compare the level of your impacted 8 with that of the 7. Okay, then whether there is any follicular space behind the impacted tooth, what is the condition of the root, whether it is single rooted or multi rooted, what is the status of 7, okay, what is the configuration of the bone, and what is the relationship of the tooth with that of the canal. All these information can be obtained from an IOPA. If you see some radio, you advise the patient IOPA, you clinically saw the patient and then you advised the patient for an IOPA. Patient went, brought an IOPA. So you're finding some radiolucency. Suppose there is some radiolucency in the apical portion of 8. Okay. Only half of the portion is visible for you. What do? You have to always advise an OPG before proceeding with the procedure. There are chances for cyst formation. Patient may be asymptomatic. If it is an OKC, patient will not find any buccal expansion or lingual expansion that grows in the anteroposterior direction. So that you cannot say that there are no chances for a cyst. So if you find a radiolucency or any change in the periapical region or any area of your IOPA, never hesitate to tell the patient to go for an OPG. After taking an OPG, you found out that there is some pathology. Okay. Again, you have to investigate the patient, advise the patient to go for a CBCT. so that you can understand where your lesion is, the three-dimensional diameter or whatever, the how long the tooth, the lesion is extending, which all tooth are involved. All that inference, all that data can be obtained from CBCT, which makes your surgery easy. Whether the nerve is involved, do you need to modify your procedure? All these inferences can be got from a CBCT. So take an IOPA. If you are not satisfied or you find that some data is missing from an IOPA, please go for an OPG. Still you are not satisfied, you find a lesion, you are not able to make out the diameter of the lesion, go forward, go for a CBCT. Never compromise your investigations. Okay, because you will not know after the procedure if there is a cyst. You will not know. You just extract the tooth from an OPG, you just took out the tooth. That cyst will be in there. The patient will be knowing it only after several years. Maybe if you have treated it earlier, patient would not have lost such a large amount of bone. So always remember to investigate the patient, and these investigations should be correlated with your clinical evaluation and the chief complaint of the patient before going for the procedure. Now, you evaluated the patient, you clinically saw the patient, you ruled out the medical history, you asked the patient for an IOP, AOPG or CBCT, you evaluated the X-ray. After that, you are assessing the difficulty index, whether I will be able to do this case, whether I am capable of taking up this case. That is the next thing to be evaluated, assessing the difficulty index. You have different classifications and different categories of assessing this difficulty index. Few among them are the Winters classification, Pell and Gregory classification, Winters war lines, and WARF assessment. At least these assessments should be performed before taking up a case for impaction. These criteria help you to judge the difficulty of your impaction and help you to will guide you to know whether I will be able to deal with this case. Am I capable of taking up this case? For that, only if you are sure to take up that case, anyone is able to do an impaction with proper anatomy and with the experience. Anyone can do this, but make sure that you can assess the case properly. What is Winters classification? According to this Winters classification, you call according to the angulation of the tooth. See, this is the last one. According to the angulation of this impacted tooth with that of the second molar, you are comparing this impacted tooth. All these are radiological evaluations. You are comparing the angulation of your third molar with that of the second molar, and you call it as either it is a vertically impacted tooth, it is a mesioangular, horizontal, distoangular, buccal, inverted. You classify it like that. So you come mesioangular is comparatively easy. You tell that mesioangular is comparatively easier than distoangular. Okay, you compare that. So you understand whether your tooth is mesioangular, distoangular, which category it belongs to. Then you are going for Pell and Gregory classification. All these are radiological classification. You have to keep your radiograph and then look at on the radiograph to understand this. According to this Pell and Gregory classification, just have a look at this figure. First figure, level A. That is the depth of impaction. Okay, the depth of impaction has been evaluated here. Whether this impacted tooth, this 8 is at the same level of this 7. Okay, that means you can see the crown of the impacted tooth, which makes your impaction easier. In level B, you can see the level of this impacted tooth is little below the crown of the 7, which means it is a little more difficult than level A. Level C, you can see that crown is completely covered and that is fully inside the bone, which makes your impaction more difficult. Similarly, you have, this is according to this first level A, level B and level C is according to the depth of your impacted tooth. Then according to the space available, here you can see the ramus relationship. This is your ramus. Are you all able to see this? I'll show you in this. This is your ramus and here is the location of your impacted tooth. So according to the space available between this ramus and the impacted tooth, according to the space available to work, that is called as this ramus relationship according to the Pell and Gregory. Second criteria is ramus relationship. That is if the mesiodistal width of the crown is equal to the distance between your ramus and the distal aspect of second molar, then your impaction will become easy. That is, there is enough space to accommodate the crown of the impacted tooth. According to level B, you can see there is insufficient space. There is only few little space available here. Just one cusp is visible here and all other part is inside the bone, which makes your impaction difficult. That is class 2. Next is class 3. The impacted tooth is completely within the ramus, which makes your impaction more difficult. So if it is a class 3 level C, then make sure that you remove ample amount of bone, that there can be difficulty. You have to split the tooth, split the bone to remove that. That is level C class 3 is more difficult when you compare that with class 1 level A. Okay. This is a radiographic finding, and always have a look at your radiograph, evaluate the tooth, understand the difficulty index of that particular tooth. This is again Winder's classification. This is again a radiographic finding which you see on the radiograph. That is, this white line indicate the level of the occlusal level of the tooth. Whether this third molar is in the same level or not, that is the white line. Again, amber line indicate how much amount of bone, alveolar bone, is covering your tooth. Whether it is completely inside the bone or whether only the root is inside the bone, that is indicated by your amber line. And red line, that is an imaginary line dropped from the white line to the point of elevation, where you have to apply the elevator. Okay, this white line, amber line, and red line changes for each type of impaction. Okay, WARF assessment. Have a look at the word WARF. WHARFE. That word W indicates Winter's classification. We already told that whether the tooth, according to the angulation of the tooth, you divided the tooth, whether it is horizontal, vertical, mesioangular, distoangular. That is Winter's classification. H is height of the mandible. You have see this. If the height of the mandible is more, okay, your impaction will be easy. You have more area to work on. So if as the height increases, your impaction becomes easier. Okay. If the mandible is small, where there is resorption and the height of the mandible is less, it will be very difficult. And if you apply inadvertent force, there are chances for your mandible to get fracture, especially in elderly patients. So always evaluate the height of the mandible. To evaluate the height of the mandible, you need an OPG. Then the angulation of third molar, root shape and configuration, whether it is single rooted, multi-rooted, whether it is involving the canal, whether it is going through the nerve, etc., can be evaluated from the root shape. Then follicular space. Follicular space is seen immediately distal to the unerupted tooth. Follicular space, availability of space increases. If you have follicular space, your impaction becomes easier. Then creating a path of exit. You should have a proper path of exit, then only this removed tooth will come out. So maintain, make sure that you have a path of exit, or you have to create a path of exit. So these are the things you evaluate from the WARF assessment. Now there are some anticipated complications. Now you evaluate this, you evaluated this X-ray, you clinically saw the case. Now you are going to talk to the patient. What are the things you should discuss with the patient? These are some of the anticipated complications which you know this is going to happen before the procedure. Okay. First is a apprehensive patient. This is the most difficult task you will find. This is you have to understand this right when the patient come to your clinic and start talking to you. Patient will be apprehensive. They'll have more doubts. They'll keep on irritating you, asking whether they'll be that, this, all that they'll keep on asking. And suppose if any complication which you have enumerated has occurred, they'll eat your head. So always make sure that you explain all the complications, all the procedure to the patient before proceeding. Nerve injury. This is an anticipated complication which you can understand from your IOPA. You can understand the position of the inferior alveolar nerve and the relationship of your inferior alveolar nerve with that of the tip of your root, the root tip. whether it is impinging on the root. Once you elevate, or if you try to move your 8, will there be any injury to the inferior alveolar nerve? That can be anticipated before the procedure, and that should be explained to the patient. You should tell the patient that there are chances for numbness of your lower lip. Is that acceptable for you? If the patient is too much worried about it, then leave the case. That you cannot avoid that. In some cases, you cannot avoid an inferior alveolar nerve injury. Next one is lingual nerve injury. While putting an incision, what happens is, instead of curving towards the cheek, if you extend your incision more posteriorly, releasing incision, you put an anterior releasing and a posterior releasing. If you extend your incision posteriorly, there are chances for damage of your lingual nerve, which is difficult to repair. After 2-3 days of your surgical removal, patient comes to you complaining that he cannot appreciate the taste of food he's having. That is how you understand that there is lingual nerve injury. Next one is vessel injury. Rare complication. Still then, keep in mind facial artery. Facial artery enters the face through the anterior border of the masseter. Okay, so when you clench your teeth, you can feel the palpation of your facial artery there. Facial artery enters, and what happens when you put your anterior releasing incision? If starters are always advised to put your incision from the inferior border towards the superior border. Never starters, okay, I'm telling about starters. Never put your incision right supro-inferiorly. What happens is, if you slip or proper bone support is not taken, if you slip your knife, there are chances to injure your facial artery. So it is always better to put your incision infro superiorly. Then inferior alveolar artery damage, that is when you are cutting the bone or when you are trying for elevation, when you keep on elevating, there is lot of bone loss. If you keep elevating the tooth, or when running a burr, there are chances for you to enter into the inferior alveolar canal and injure the inferior alveolar artery. Next one is adjacent crown dislodgement. All this should be explained to the patient. If you find a crown on the adjacent tooth, always inform the patient there is a crown, and when I elevate 8, there are chances for crown displacement. So keep in mind, explain, and then only proceed. Status of the adjacent tooth. Always evaluate the adjacent tooth, whether it is grossly decayed, whether it is periodontally involved, or whatever issue there is for adjacent tooth. Do explain to the patient before the procedure or after the surgical procedure. That blame will be on you. Coming into the surgical procedure, I would like to know whether you are able to follow.
Right, we can hear you, ma'am.
Okay. Coming into the surgical procedure, all the surgical procedures, whether it is minor or major, everything should be done under proper aseptic technique. Autoclave your instrument, your instruments, your LA, needle, everything should be should have this asepsis, and this sterilization protocol should be followed. First, LA. In the surgical procedure, LA, when you hear local anesthesia, what is the relevance? You are just giving that, finished. It is not like that. Post-operative, if you want to minimize your post-operative edema or your post-operative complications, each and every step you should be aware how to minimize the injury and insult to the underlying tissues. Every procedure, you should be very careful to reduce the insult to the tissue. Then only you will have a good post-operative period. The patient will have the least post-operative complications if you manage it from LA. When you give LA, always make sure that your needle and the solution is sterile. If you place your needle over your table, over your working space, you place it somewhere else without the cap, what happens is, when you take this needle, you inject into the space, you are injecting a unsterile solution into a space, and that can cause a space infection, a pterygomandibular space infection post-operatively. Then while giving LA, always make sure that you are giving a slow injection, a very slow injection. Take time, avoid repeated injections. If you avoid repeated injections, that itself can make the post-operative period happier. Okay, incision again, you have to keep in mind the vessels which are going nearby, the principles of your flap design, etc. should be kept in mind. Then you are reflecting the flap, then you are going for your buccal guttering, you remove the bone, then you section the crown if required, then you elevate your tooth and root, then you smoothen the edges. Now that will be roughened all around, that will be rough. You smoothen all your bony edges, toilet your wound, suture, give medications, and the post-operative care. This is the steps involved in removing an impacted tooth. The first step is LA. For an impacted 8, we usually give an inferior alveolar, lingual, and a long buccal nerve block for the mandibular molars. Make sure that you avoid repeated injections. These repeated injections can injure your medial pterygoid muscle. Here you can see your medial pterygoid muscle. This yellow is your target. This is your nerve. So this medial pterygoid, if you repeatedly inject your medial pterygoid, what happens is this insult to the medial pterygoid causes post-operative trismus. So always try to give a injection in a single shot, that too very slowly. Incision. Here you can see in this picture, you can see there's an anterior release. Most commonly to remove an impacted tooth, you give either a Watts incision or a modified Watts incision. This is Watts incision. This is the incision that is commonly done. Here you can see an anterior releasing incision and a posterior releasing incision and a connecting limb here. This posterior releasing incision, if you are supposed to curve your posterior, this is your posterior releasing incision. This posterior releasing incision should be curved towards the cheek. Why? Why do you want to curve this incision? You can put it right straight there. You have enough of space here. You can just go straight like this. If you do that, you will be injuring your lingual nerve. There you have many unnamed arteries. You can come across bleeding there. Then there is your insertion of your temporalis muscle. The fibers of your temporalis muscle are inserted here. If you cut it straight like this, then all three of this will be in danger, and that will cause post-operative complications. To avoid that, you curve your incision towards the cheek. Okay. Your anterior releasing incision, as already discussed, it is advised to place your incision infra-superiorly. Put your incision from the inferior part to the superior part. If you put it right like this, it is okay for experienced people, no issues. As a starter, it is always better to, if you are a starter, it is better to place your incision from infra-superiorly and make sure it is a clean incision. Don't move your, just put an incision, look, then continue. Not like that. Put a single stroke incision that should be deep and that it should be firm on the bone. While putting an incision, make sure that you are not including any anatomically relevant structures. After this incision, you reflect this. Before this incision, you are evaluating whether this incision is required. If your incision is, you put an extensive incision, what happens post-operatively? There will be some trismus. Keeping that in mind, you should never compromise your flap design that compromises your accessibility and visibility. Always make sure to do an impaction, to remove a tooth surgically. Always make sure that you have enough accessibility and visibility to your field. If not, the entire procedure will be messed up. So the first step, make proper incision. It is told that you have to limit your incision. That is fine, but don't limit your incision, keeping in mind that you have limited access and visibility. Okay. After that, you reflect the flap. Now you can see your impacted tooth, the bone around, and keep in mind the position of the nerve. One more thing in incision, when you are putting an incision, I told you, put a single stroke incision firmly on the bone. Make sure that you incise the periosteum too. Always incise the periosteum in that single stroke. If you keep the periosteum there and if you keep stripping the periosteum, you will experience bleeding in right from incision. If it's a clean incision involving the periosteum, then there are very less chances for you to experience bleeding in this stage, that is the incision stage. After reflecting the flap, you see your tooth and you see the bone around. Always before going for bone cutting, keep in mind the tooth belongs to the surgeon and the bone belongs to the patient. Always maintain minimal bone cutting. That can reduce your post-operative edema. Okay. You're going for a buccal guttering. That is, you gutter using, there are three size burrs, that is 701, 702 and 703. 703 is used mostly to cut the tooth. Okay, so if large chunk of tooth is gone, there is no much issue because tooth has to be removed. Bone, if large amount of bone is removed, if you put a 703 burr and try for a buccal guttering, a large amount of bone will be removed, which makes the post-operative period eventful. So always remember to cut, it is always better to cut the bone with 702 burr so that minimum amount of bone will be removed. Why not using 701? If you try to remove the bone with 701, what happens is that there are chances for the burr to break. That is so thin. So if you miss a root tip and all, you can cut with the 701. But if there is a whole chunk of bone and tooth there, it is better to cut with a 702 burr. Okay, after cutting with the 702 burr, during this procedure, during buccal guttering, make sure that you irrigate the area with the chilled saline, so that your osteocytes, the death of the osteocytes can be prevented to a certain extent, which helps you to make your post-operative period uneventful. In some cases, I've seen some of the practitioners telling you can also cut with a handpiece, aorta handpiece. Ideally speaking, that is not advised. That is because there can be air emphysema there. Next thing, this aorta, the liquid coming out, it is very easy to cut with an aorta. That is all. We need not irrigate the saline already. That is coming out, water is coming out from the handpiece. But what happens is that you are introducing an unsterile solution into a sterile surgical field. The water coming out from this aorta is not sterile, and the field where you're working is sterile or supposed to be kept sterile. So it is better to avoid cutting with the handpiece, this aorta. Second thing is the heat dissipation will be better if you use a chilled saline, and this water coming out from this aorta is not a physiologic solution, so there are chances for osteocytic death. So it is better to use a micromotor handpiece along with chilled saline. There are two methods of this buccal guttering. You can either use micromotor handpiece or a chisel and mallet, but now chisel and mallet, very rarely we use this chisel and mallet. All are using micromotor handpiece for better ease of doing. All are using a micromotor handpiece. Next step is you gutter the tooth. You evaluate whether you will be able to elevate this tooth or not. You try elevation. No, there is block somewhere. You need to proceed with the buccal guttering. Another thing in this figure is here you can see the midline of the tooth is here. In this figure you can see the midline is here. Never extend more than 3/4 towards the lingual side. You always keep 1/4 of the bone there in the lingual aspect of your impacted tooth. You can gutter this tooth up to 3/4 of your tooth. Okay, 1/4 should remain there. So once you tried for elevation, you found that elevation, there is some block somewhere, you need to split the tooth. That is, if you remove so much amount of bone, if you keep removing the bone like this, post-operatively, the patient will have so much of difficulty. So you understood there is a block there, and now you are going for a crown splitting. Here you are cutting, you are supposed to cut the tooth in a wedge shape. Always the inferior portion should be narrow than the superior chunk of your tooth. That is for the easy removal of this tooth. You have to always split your tooth like this. The inferior portion should be narrow, slender. Then only you will be able to elevate. In some cases, we see that the doctor might have split, crown splitting will be done, and the doctor will complain that this tooth is not coming up. The fault there is the doctor has split the tooth in the reverse. That is, the wedge portion, the narrow slender portion will be on the superior aspect of the crown, and this chunk will be in the inferior part. Then this crown will not be able to come out. So always keep in mind that to make your inferior portion, the edge of this crown split during slender. Then only you will be able to remove this tooth. Whichever, according to the case, either you can split the tooth vertically, you can split the whole tooth vertically, or you can first remove the crown, then the root, or you can remove a part of the crown, just a part of the crown, and try for elevation. That depends on the surgeon and the case scenario. That is up to the surgeon who is doing this. Now you found, you know the path of exit. You rotate, you elevate the tooth comes out. Okay, you can see there are ragged borders. After this removal, you need to smooth this out without disturbing the blood flow. Cure it here. If there is any follicular tissue there, remove that. Irrigate the socket. Smoothen your edges. Bony edges should be smoothened. You suture the socket. After hemostasis is attained, suture the socket. Postoperative complications. Now, if you keep your incision minimal, bone removal minimal, then your postoperative complications will also be minimal. It is always better to prevent a complication, okay, rather than treating your complication. So an ounce of prevention is always better than a pound of cure. The clinician should have thorough knowledge about the anatomy, proper clinical and radiological assessment prior to surgery. Follow proper aseptic precautions, surgical principles, and evaluation of the case that can help us to prevent many of the post-operative complications. Complications during an impaction can occur during the surgical procedure, immediate post-operative period, and the late post-operative period. So during the operative procedure, during the incision, during bone removal, during tooth sectioning, and during elevation of the tooth, there can be complications. So what are the things to be kept in mind during each step? During an incision, I already told you that there can be chance of injury to the facial artery, bleeding of the retromolar vessels. That is, if you give a straight incision posteriorly, instead of curving your posterior incision towards the cheek, if you give a straight incision, there can be bleeding from the retromolar vessels. This bleeding between, if you get this bleeding between the procedure, that is much irritating for you to complete the procedure. So if you keep some tips in mind, you will get a clear feel, which makes your procedure easy. Okay. Then damage to the lingual nerve, instrument slippage. Whenever you use any instrument, always take proper support, then only use this instrument, especially elevators. When you are trying for an elevation, you are not, if you find that there is difficulty in this elevation, please don't keep nicking the tooth. That is neither not going to come. You will slip the instrument and that will go to the floor of the mouth, damage the adjacent structures. So keep in mind all these steps when you place an incision. During bone removal, I don't think we commonly use a rotary instrument. I don't think chisel is commonly used. Till then, I have included that here. By using a rotary for removal, there can be accidental burns. How? That is, if you keep using a micromotor repeatedly, and if the bearing is, there is some issue with the bearing of the instrument, then you are continuously using that. With a gloved hand, you will not be able to appreciate the heat dissipation on the instrument. But the area which comes in contact with the micromotor will get burned if there is heat generated from that of your micromotor. Then laceration of soft tissues can occur, that is due to accident, slippage, or improper use of instruments. Then injury to the inferior alveolar bundle, that is if the bone is removed more of a, or if you get a dip to the bone without proper stop, after proper guttering, if you go again deep, then you can injure your inferior alveolar bundle. Then injury to the adjacent tooth. This is commonly seen when you attempt a disto-angular tooth. Your crown will be visible and the root will be towards the mesial aspect. You keep removing the bone around the mesial aspect of the root and you damage the 7 and the root of 7, trying to remove the bone around 8, the mesial aspect of the 8. Then injury to the lingual nerve, necrosis of the bone, emphysema. By using chisel, when you are, there can be splintering of the bone, there can be fracture of the mandible. By using chisel, you always put stop cuts. That is, once you are using your mallet, instead of slipping, to avoid slippage, you block this bone with a 2 stop cuts, so that your bone, the bone will be cut in only those particular area. There can be chance of fracture of the mandible. Then again, if you keep giving force, what happens? Your tooth will be displaced into the lingual pouch. There can be injury to the lingual nerve, injury to the second molar and soft tissues. Now, during sectioning of the tooth, by using a rotary, there can be incorrect line of sectioning of the crown. When we start sectioning the tooth, what we think is, I should get a perfect cut of this tooth, equal halves, 2 equal halves. But incorrect line of sectioning of the crown, that will get corrected by experience. Injury to the mandibular 701 burr, there are chances for breakage of the burr, so it is better to use a 702 burr. Use of an osteotome, there can be fracture of the mandible, TMJ dislocation, traumatic arthritis, slippage of the instrument, and excessive force can be the complications of using an osteotome. While elevating a tooth, when we try for elevation, if you find any resistance, please stop, section the tooth. Okay, that should be kept in mind. If you keep elevating the tooth, if you are giving force and you are keeping on elevating the tooth, you are trying the wrong technique over and over again, the tooth is not going to move. That can result in fracture of this impacted tooth, injury to the second molar, fracture of the mandible, displacement of this tooth or this root into the submandibular space, sublingual pouch, or into the inferior alveolar canal. Instrument slippage and damage to the tongue or the floor of the mouth. If you give excess force, that can cause TMJ dislocation. Accidentally, that can get aspirated or swallowed. Post-surgical complications, patient might complain of bleeding, edema, pain, trismus, infection, hematoma, or surgical emphysema. Then nerve injury, TMJ complication, periodontal pocket formation, distal to the second molar. If you compromise, if you don't suture properly, there can be periodontal pocket formation post-operatively. Then rare cases, rarest of the rare, there can be osteomyelitis. Risk management, managing the unavoidable. Though I told you, you can manage or you can minimize the post-operative complication. You can only minimize. Certain complications are unavoidable while trying to remove a impacted tooth. So you have to manage those unavoidable complications. First one in that is, after wisdom tooth removal, there is some swelling. If you have removed bone, if there is some insult to the tissue, then you have to accept that there will be some swelling post-operatively. This is unavoidable. However conservatively you remove the bone, however small your incision is, still then there will be some swelling. You can just compare the swelling of this patient with that of your previous patient. Only that can be done, but there will be swelling. Then there is chance of trismus. What are the ways to avoid this trismus post-operatively? Inform the patient that there will be a minimum amount of trismus. You can use proper injection technique and slow injection to minimize this trismus. While putting an incision, always keep in mind not to extend your posterior releasing incision more posteriorly to damage the fibers of the temporalis muscle. That can again cause trismus. Keep these things in mind. Always use a sterile solution and a sterile needle. That can also cause infection, and again patient comes complaining of trismus. Post-operative care, you ask the patient, you do all the procedure well, there is minimum bone removal, you sutured well, hemostasis is attained, you give medications, you send the patient. Okay, this is what you tell the patient. When the patient first comes to you, you tell the patient, you take your wisdom tooth, everything will be fine, and this is how your patient will be after removal. So this should be acceptable for the doctor as well as the patient. So always tell the patient that there will be some difficulty or some complications post-operatively when you remove your wisdom tooth. So let me conclude. First thing is, you should have a proper anatomy. To do a proper surgical removal, you should have a proper knowledge of the anatomy of where are the structures, what is related to what. When I am giving LA, which are the structures I am penetrating through. All this should be kept in mind while putting an incision. Which are the structures to be avoided? All this should be kept in mind when you proceed, or when you see a case, or when you see an X-ray. Okay. After that, you should have a vision of what you are going to do. Okay. How am I going to remove this tooth? Make a clear surgical plan. You should, of course, put some of your skills into that. You have to properly evaluate the case clinically and radiographically. Never hesitate to evaluate the patient. By experience, you keep improving each day. You improve, you will be better than yesterday today. Keep learning. Be aware that what you will be able to do. Will I be able to do this case or not? And what not to do. That should be, we should be aware what I should not do, or at what point I should stop and call a surgeon, or whether I'll be able to proceed. That you should be aware before starting the case. With the help of technology, will help you to a certain extent. Ask after the diagnosis, evaluate. You will be able to make your case a little better. Then never give up. If not today, you will learn tomorrow. It is theory into practice. So you need some of your theoretical knowledge. Some, at least few things you should know theoretically before putting into practice. It's not about having the skill to do something. It's about having the will, desire, and commitment to do your best. Anyone can do a surgical removal. Only you need the will, desire, and commitment to your best. You will be doing better each day. If not today, tomorrow you will learn. Thank you.
It was a beautiful class. Thank you, ma'am. Any questions now? Anyone? Actually, the class was very inspiring also, in spite of all the complications that could arise, which ma'am told. If anyone wants to ask, they can unmute their microphone and
Madam.
Right, Shaju sir.
Paresthesia on the temporary anangilum. Paresthesia on the extra Sadhana medication in London. In Neurovine Volta Kurkan role.
Sir, paresthesia വരുമ്പോൾ നമ്മളടുത്ത് പേഷ്യന്റ് എപ്പോൾ റിപ്പോർട്ട് ചെയ്യുന്നു എന്നുള്ളത് അടിസ്ഥാനപ്പെടുത്തിയിട്ടാണ് അത് വരുന്നത്. ഇപ്പൊ പേഷ്യന്റ് ഇമ്മീഡിയറ്റ്ലി പരസ്തീഷ്യ എന്ന് പറയുകയാണെങ്കിൽ നമ്മൾ ന്യൂറോബയോൺ ഫോർട്ട് കൊടുത്തിട്ട് നമ്മൾ ഒരു 1 month നോക്കാം. 1 month കഴിഞ്ഞിട്ടും കംപ്ലൈന്റ് മാറുന്നില്ലെങ്കിൽ പിന്നെ അത് മാറാനുള്ള ചാൻസ് വളരെ കുറവാണ്.
വിധി പിന്നെ പേഷ്യന്റ് പറയാം നിങ്ങളുടെ വിധിയാണെന്ന് പറയല്ലേ.
അതെ സർ, കുറച്ച്
ക്ലിയർ ആവുന്നില്ല ചില സമയത്ത്.
മാഡം, ഈ പോസ്റ്റ് ഓപ്പറേറ്റീവ് സ്റ്റീറോയിഡ് കൊടുക്കുന്നതിനെ പറ്റി ഒപ്പീനിയൻ.
അശ്വതി ഡോക്ടർ, ഹലോ, കേട്ടോ? ഹലോ,
റേഞ്ച് പോയി ഡോക്ടറെ.
കേട്ടില്ല സർ.
Anthony sir, please repeat.
Ma'am, what is your opinion regarding giving post-operative steroid?
So post-operative steroid കൊടുക്കുന്നതിനേക്കാൾ നല്ലത് ഒരു 8 steroid pre-operatively കൊടുത്താൽ നല്ല റിസൾട്ട് ഉണ്ടാവും സർ.
ഓക്കേ, ഏതാ കൊടുക്കണ്ടേ?
ഡെക്സോണ സർ, 8 mg ഡെക്സോണ ഇഞ്ചക്ഷൻ IM.
What about oral? There are limitations for giving IM, no? Dexona.
കൊടുത്താലും പ്രീ ഓപ്പറേറ്റീവ്ലി കൊടുക്കുന്നതാണ് ഒരു ബെറ്റർ റിസൾട്ട് സർ. പോസ്റ്റ് ഓപ്പറേറ്റീവ്ലി നമ്മളൊരു ലോങ് പ്രൊസീജിയർ ചെയ്യുന്നതിന് മുമ്പ് അങ്ങനെ റിസൾട്ട് കാണാറുണ്ട് സർ.
ജസ്റ്റ് ഇമീഡിയറ്റ്ലി ബിഫോർ ദ പ്രൊസീജിയർ ആണോ മാഡം? പീരിയഡ് ഉണ്ടോ? ചെറിയ നെറ്റ് ഇഷ്യൂ ആണ്, അവർ ലോഗ് ഔട്ട് ആയി പോയി. ഹലോ,
കേൾക്കുന്നുണ്ടോ?
കേൾക്കാം. റൈറ്റ്, കേൾക്കാം. അപ്പോ അതിന് ഇത്ര സമയത്തിന് മുന്നേ കൊടുക്കണമെന്നുണ്ടോ അതോ ഇമീഡിയറ്റ്ലി ബിഫോർ ദ പ്രൊസീജിയർ ആണോ?
ക്ലിയർ ആവുന്നില്ല. ഒന്നും കേൾക്കുന്നില്ല.
ഹലോ,
കേട്ടില്ല.
അശ്വതി ഡോക്ടറെ, ഹലോ. ഡോക്ടറെ, ഹലോ.
അതെ, ഇൻ ബിറ്റ്വീൻ കട്ട് ആയി പോയി, സോറി.
റൈറ്റ്, വേറെ ക്വസ്റ്റ്യൻ എന്തെങ്കിലും ഉണ്ടോ?
ഒരു ക്വസ്റ്റ്യൻ ഉണ്ട്. നമ്മള് മൈക്രോമോട്ടർ യൂസ് ചെയ്യുന്നതിന് പകരം ഫിസിയോ ഡിസ്പെൻസർ യൂസ് ചെയ്യുന്നതിൽ എന്തെങ്കിലും അഡ്വാൻറ്റേജ് ഉണ്ടോ ബോൺ കട്ടിങ്ങിന്?
അഡ്വാൻറ്റേജ് ഉണ്ട് സർ.
ഓക്കെ,
അഡ്വാൻറ്റേജസ് ആണ്, പക്ഷെ അത് എല്ലാ സ്ഥലത്തും നമുക്ക് യൂസ് ചെയ്യാൻ
അവൈലബിൾ അല്ല. ഓക്കെ, ആക്സസിന് എന്തെങ്കിലും പ്രോബ്ലം ഉണ്ടോ കൂടുതൽ?
ഉണ്ടാവും സർ. ഇത് നമ്മളിപ്പോ പോസ്റ്റീരിയർലി കട്ട് ചെയ്യുമ്പോഴെല്ലാം നമ്മളെ ഇത് ഹാൻഡ് പീസ് സ്ട്രൈറ്റ് ആയതുകൊണ്ട് അതിന്റെ ലിമിറ്റേഷൻ ഉണ്ട് പോസ്റ്റീരിയർലി പോകുമ്പോ. അപ്പൊ അതൊക്കെ കുറച്ചും കൂടി ഈസി ആയിരിക്കും.
കോൺട്രാങ്കിൾ ആയതുകൊണ്ടല്ലേ?
അതെ.
Anyway, the class was very motivating and encouraging. Very good.
റൈറ്റ്, ഇനി എന്തെങ്കിലും ഡൗട്ട് ഉണ്ടെങ്കിൽ ചോദിക്കാം. പറഞ്ഞോളൂ, സ്ലൈറ്റ് ആയിട്ട് കേൾക്കുന്നുള്ളൂ. ആരാണ്? ഭയങ്കര ഫെയിൻഡ് ആയിട്ട് കേൾക്കുന്നത്. ഒന്നുകൂടി ഒന്ന് ഉറക്കെ പറയാോ? മൈക്ക് അടുത്ത് വെക്കോ? എന്തെങ്കിലും തീരെ കേൾക്കുന്നില്ല. ഓക്കെ,
ഒരു 60-65 എബോ ആയിട്ടുള്ള പേഷ്യൻസിന്. ഹലോ,
കേൾക്കാം. 65 ഇയേഴ്സ് ആയിട്ടുള്ള പേഷ്യൻസിന്
ഇപ്പൊ എക്സ്ട്രാക്ഷൻ ചെയ്യുന്ന സമയത്ത് ഭയങ്കര ഫാം ആയിട്ട് ഒരു ആൻകൈലോസിഡ് പോലെയാണ് തോന്നുന്നത്. അപ്പൊ നമ്മൾ കട്ട് ചെയ്ത് കഴിഞ്ഞിട്ടുണ്ടെങ്കിലും റൂട്ടിന്റെ ടിപ്പ് വരെയും കട്ട് ചെയ്തെടുക്കേണ്ട ഒരു അവസ്ഥയാണ്.
ഏജ്ഡ് പേഷ്യന്റിനല്ലേ മാഡം?
അതെ, 65 ഇയേഴ്സ്
ഏജ്ഡ് പേഷ്യൻസിനാകുമ്പം ആകുമ്പം അപ്പൊ നമ്മള് എത്ര കട്ട് ചെയ്തിട്ടുണ്ടെങ്കിലും നമുക്കത് അവസാന പീസ് വരെ കട്ട് ചെയ്ത് എടുക്കേണ്ട ഒരു അവസ്ഥയാണ്.
അതെ മാം, അത് നമുക്ക് ഒന്നും ചെയ്യാൻ പറ്റില്ല. അവരെ ബോണിന്റെ ഇലാസ്റ്റിസിറ്റി എല്ലാം പോയിട്ടുണ്ടാവും. അപ്പൊ അത് വളരെ ബ്രിട്ടിലായിരിക്കും. ഇനി ആ ലാസ്റ്റ് ഒരു പോയിന്റ് ആണെങ്കിൽ അവിടെ വെച്ചിട്ടാണ് അത് പൊട്ടുക. അപ്പൊ ആ പീസൊക്കെ ഉപേക്ഷിക്കുക എന്നല്ലാതെ അതിന് നമുക്ക് ഒന്നും ചെയ്യാൻ പറ്റില്ല. ആ ബോണിന്റെ അത്രയും ബുദ്ധിമുട്ടായിരിക്കും അത് കിട്ടാൻ. ഇനി അറ്റ്ലീസ്റ്റ് ഇപ്പൊ ഒരു 1/4 ഉണ്ടെങ്കിൽ ആ 1/4 റിട്രീവ് ചെയ്യാൻ ട്രൈ ചെയ്യുമ്പോൾ ആ ടിപ്പ് പൊട്ടും.
അതെ, ടിപ്പ് പൊട്ടുകയാണ്.
അതെ മാം, അതൊക്കെ എല്ലാവർക്കും.
അപ്പൊ നമുക്ക് എന്തെങ്കിലും ഒരു സൊല്യൂഷൻ ഉണ്ടോ?
ഇല്ല മാം, അതിനൊന്നും ഒരു സൊല്യൂഷനും ഇല്ല. കുറച്ചും കൂടി വൈഡ് ആയിട്ട് കട്ട് ചെയ്ത് നോക്കാമെന്ന് മാത്രം, അത്രയും ബ്രിട്ടിലായിരിക്കും.
ഓക്കെ ഓക്കെ. അപ്പൊ അത് നമുക്ക് എത്ര വരെ ലീവ് ചെയ്യാത്?
1/4 ആണെങ്കിൽ ഇഷ്യൂസ് ഇല്ല മാം. അങ്ങനെ
എത്ര millimeter വരെ?
ലീവ് ചെയ്യണം എന്നല്ല, ചെയ്യണം.
ഇനി അതിലും കൂടുതൽ 1/4 പ്രഖ്യാപിച്ചോണ്ടാവും ഇത്, അല്ലെങ്കിൽ വേറെ രക്ഷയൊന്നുമില്ല.
I think inform the patient and let that patient come back for review. അത് തന്നെയാണ് സംഭവം തോന്നുന്നത്. അവരടുത്ത് പറയാം,
അതേ നമുക്ക് ചെയ്യാൻ പറ്റുള്ളൂ.
റിവ്യൂവിൽ വെക്കുക പേഷ്യന്റിനെ, റീഅഷ്യൂർ ചെയ്തിട്ട് മേക്ക് ഷുവർ ദാറ്റ് പേഷ്യന്റ് കം ബാക്സ് ടു യു. വേറെ ക്ലിനിക്കിലൊന്നും പോവാതിരിക്കുക.
വേറെ ക്ലിനിക്കിൽ വന്നാലും ഇതാണെന്ന് നമ്മൾ റിവീൽ ചെയ്യരുത്. നമ്മളത് എടുത്തു വിടുക എന്നല്ലാതെ ഇങ്ങനെ ഉണ്ടായിരുന്നു എന്ന് ഒരിക്കലും നമ്മൾ പറയരുത്.
Right. Right. വേറെ ക്വസ്റ്റ്യൻസ് ഒന്നും ഇല്ലെങ്കിൽ ഐ തിങ്ക് വി കൻ വൈൻഡ് അപ്പ് ദ സെഷൻ. 1 മണിക്കൂറോളമായി. നമ്മൾ 45-50 പാർട്ടിസിപ്പൻസോളം ഉണ്ടായിരുന്നു നമ്മുടെ സൂം മീറ്റിംഗിൽ. ലൈവ് സ്ട്രീമിംഗിൽ 6 പേര് വരെ വന്നിട്ടുണ്ട്. Right. And if anyone wants to go back and review the session, it is available in our YouTube channel. Dr. Shaju Mandoli, our president, will say a few words.
Hi, Dr. Aswathi. വളരെ ഭംഗിയായിട്ട് പ്രസന്റ് ചെയ്തു. ഒരു വെബിനാറിന്റെ ലിമിറ്റേഷൻ നിന്നുകൊണ്ട് ചെയ്യാവുന്ന മാക്സിമം ഞാൻ സ്വീപ്പിക്കാൻ പറഞ്ഞിട്ട് വളരെ നന്നായിട്ട് പ്രസന്റ് ചെയ്തിട്ടുണ്ട്. ഡോക്ടർ പറയാനുള്ള കാര്യം ഓരോരോ വാക്കുകൾ നല്ല സ്ഫുടമായിട്ട് ഞങ്ങൾക്ക് മനസ്സിലാകുന്നുണ്ട്. നല്ല ബ്യൂട്ടിഫുൾ പ്രസന്റേഷൻ. ഒറ്റ കാര്യം കൊണ്ട് അവസാനിപ്പിക്കാം. യു ആർ ഗോയിങ് ടു ബി എ വെരി ഗുഡ് ടീച്ചർ. Thank you.
Okay, thank you ma'am for your valuable time. ഇത്രയും നേരം ഒരു Sunday morning.
1 minute. I'd like to acknowledge the presence of Kunyamma ma'am.
Right.
Ma'am, I'm so grateful to you for attending this session, ma'am. This makes me more happy, ma'am.
Nicely presented, Aswathi. I was eagerly waiting for your lecture to hear.
Thank you, ma'am. With your blessings, ma'am. All because of your blessings,
you have highlighted the point, no? To know what should not be done more than what to do. It's a very, very good point that to be highlighted.
Thank you, ma'am.
I appreciate it. Thank you. Well done.
Thank you, ma'am.
All the best.
Thank you, ma'am. I would like to thank Dr. Samira Jinath. I would say that she's a synonym to IDA Malabar branch. She works so immensely for this branch, and it is she who has motivated me to come over here and share this platform with you. I'm so grateful for her for motivating me and bringing me here. So thank you, ma'am. And thank you all the members who are here, the office bearers and everyone for giving me this platform. Thank you so much.
Thank you, ma'am. Okay, we'll wind up the session now.